Hello, dear colleagues, and welcome to part 3 conversation on norepinephrine, a deep dive where we explore the unmet needs and its use in clinical practice. I'm Rakesh Jain, and as I said, this is part 3 of our conversation. This time, we're going to focus on clinical interventions. What can we do to help ourselves or our patients if they have trouble with norepinephrine or noradrenergic abnormalities? It is really important to remember this point before we go any further, that hyperarousal symptoms that we talked about in parts 1 and part 2 are in fact very common in clinical practice. And the symptoms of hyperarousal can be diverse. They can include all the way from insomnia, agitation. It can include irritability, distractibility. It can also include trouble with attention span. And needless to say, depression and post-traumatic stress disorder are deeply intertwined with this condition. Remember, hyperarousal symptoms are very problematic. Certainly, hypoarousal symptoms are also quite challenging. And you really want to add salt to the wound? I'm afraid SSRIs and SNRIs sometimes, in fact, probably more than sometimes, add to the problem because they reduce norepinephrine functioning, thereby setting up the patient to suffer even more with an over-regulation disorder. You met patients, haven't you? Perhaps you have them in your family too, who have been on SSRIs and SNRIs sometimes for decades. And what they report is a flattening of affect, flattening of mood, apathy, don't want to do anything, not necessarily depressed, but that's almost like colors being taken out of their life. That often, as I want to show you, is induced by serotonergic medications, and we think of that as a norepinephrine over-regulation set of challenges. That's a problem because we now have a patient we're trying to help, and we end up giving them problems like, here we go, lassitude, loss of energy, slowness of thinking. Patients often say, I have a blank mind. I can't believe I'm a physician or an engineer, but pretty much what I have is a blank mind. Their concentration is difficult. They talk about learning difficulties, sleep difficulties, appetite loss, etc. So please remember, SSRIs can in fact worsen challenges with norepinephrine. And if you think I'm being too bold in making that statement, there's clinical evidence to support it for sure, but the research data for years has pointed to this challenge. This study is almost from 20 years ago, where it was found that patients exposed to an SSRI, in fact, had changes in the norepinephrine turnover, thereby denoting in a fair number of patients, probably 30 to 40% of patients, the presence of these classic antidepressants do in fact worsen norepinephrine functioning. Be very mindful of this problem. It happens quite a bit. So while we have used norepinephrine reuptake inhibitors as the primary tool for intervening with norepinephrine. Remember, this section focuses on the treatment of noradrenergic abnormalities. That is now thought to be a very blunt tool because what reuptake inhibitors, including norepinephrine, do is they change things everywhere in one direction only. But if you do it with some thought and care by going directly after norepinephrine receptors, you can actually do a lot of good for patients. So check out this illustration. We have direct presynaptic receptor interventions available now. So for example, remember the alpha family? There was alpha 1 and alpha 2. Well, alpha 2 primarily lives above, if you will, presynaptically, where they have very high sensitivity to norepinephrine. And over there, they act primarily as brakes, as antagonists. So if you stimulate a alpha 2 family member, pretty much it decreases the tone of norepinephrine. On the other hand, if you stimulate an alpha 1 family member that lives below, it's postsynaptic, it tends to be a stimulant, therefore an agonist. So this dance between the braking mechanism and the accelerating mechanism in the brain, in fact, is the reason why most of us who don't have norepinephrine abnormalities can modulate our energy, our mood, our sleep, everything about us we are able to control, but our poor patients aren't able to. That's why these direct receptor activity drugs on alpha 2 family members or alpha 1 family members are rapidly emerging in the field as gold standards. So this broad spectrum approach to attacking norepinephrine has a class now. So atypical antipsychotics, certainly some of them, are now thought to have a significant amount of norepinephrine benefits for our patients. And here I've just brought for you two different atypicals to consider, because atypicals are in fact quite different from each other. So atypicals aren't just a class of similar looking compounds. They in fact don't have all that much similarity. They have more dissimilarities than similarities, which is great. So here I'm just using two medications as examples, brexpiprazole and aripiprazole, to show how different they can be from each other. Not to say one's better than the other or any atypical's better than the other, but it does appear when it comes to norepinephrine, the abilities are quite different in these medications. And the reason why these atypicals are of such great interest is because they don't act as reuptake inhibitors. They do not do that at all. They actually go after the receptors themselves, both members of the alpha-1 family and members of the alpha-2 family. So much more of a targeted activity on that abnormal system in a patient. So the important point to remember is medications do have a role, and we should be very thoughtful about how we go after it. But we should also be reminded no conversation on norepinephrine is ever complete without talking about non-pharmacological interventions, and I would like to talk about three. And all of us should be doing it, all of us, and definitely our patients. That would be sleep hygiene, exercise, and of course, yoga and mindfulness practice. So let's first talk about sleep. And you might be wondering, why would we want to talk about sleep and norepinephrine while I'm awake? It should be more just during sleep. Not so, not so. A person who's not sleeping well, has insomnia, even when they're awake, often have an abnormally activated norepinephrine system. So when people say, I feel jittery when I don't sleep well, but I also feel tired at the same time, believe them. Because norepinephrine and the neurobiology of sleep and exercise are deeply intertwined. So much so when it comes to exercise, that's what I'm showing you here, is folks who exercise certainly temporarily have an elevation in the norepinephrine tone, but generally speaking, after the first few hours have gone, they have long-standing positive control over norepinephrine tone. You've probably seen that very good athletes often have a very low resting heart rate. That's the way we are able to understand it. And there's a reciprocal and positive relationship between both norepinephrine increase and decrease and exercise. It's really important. So please remember three things. Fatigue and impaired cognitive functions are often connected to definitely norepinephrine, but dopamine has a role there too. Physical activities do in fact change the tone of these neurotransmitters. Definitely change the amount, but also the tone. And in depression, where norepinephrine and dopamine abnormalities are so common, it is very important to think about sleep hygiene and sleep restoration and physical exercise as potent interventions in management of norepinephrine challenges. And I would be remiss if I did not point out to you the very important value of meditation or yoga and meditation in terms of a variety of benefits, but certainly from a norepinephrine perspective. So we do know that thalamic GABA changes when individuals meditate. When people say, I feel calmer after meditation or yoga, they're not just making it up. Their brain literally is giving out signals. But also note, when the parasympathetic nervous system is modulated appropriately, so is the sympathetic system. And norepinephrine is a prominent member of that. So these three non-pharmacological interventions are top-notch interventions in terms of the modulation of norepinephrine, both in health and in illness. And if you are a healthy individual and want to prevent mental illness, I think it would be very wise to consider all three of these interventions as your best friends. Sleep hygiene, physical exercise, and a meditation or yoga practice. And this rule, by the way, also applies to someone who is suffering from a psychiatric condition like an anxiety disorder or a mood disorder. I'm really trying to emphasize to you that norepinephrine, when managed well, is a very good friend of ours, and non-pharmacological interventions really do help. You will like this as we start concluding our conversation, because norepinephrine sits right in the middle of these three very important functions or dysfunctions of the human brain when we are depressed or anxious, etc. First of all, we have limbic hyperactivity. We think too much. We ruminate too much. We also have cognitive dysfunction. That's the dorsal cortical dysfunction I'm showing you on the right. But we also have a pleasure circuit dampening. All three of these happen at the same time in people who have norepinephrine difficulties, and norepinephrine sits right in the middle of these three. See, this is a reason why I and you are having this conversation. So we have interventions. We have cognitive behavioral therapy that goes after the dorsal cortical dysregulation. We have positive activity interventions as physical exercise, for example. And then, of course, we have pharmacotherapy if necessary to dampen the tone of this overactive limbic system. So one way or another, norepinephrine, when disrupted, creates trouble. It appears to be that it creates trouble in all three zones. The good news is you and I have the knowledge and the wisdom and the studies to back up interventions with all three of these systems. Okay? And often we combine the interventions. That's what I'm showing you with the final build on this slide. Okay, let's summarize our time together. First of all, norepinephrine is very widely distributed. It has been under-discussed. I don't know why. Maybe because serotonin stole all the thunder in the 70s and 80s, and we forgot about norepinephrine, but today it's time to be reacquainted with it. Please remember, norepinephrine too much, norepinephrine too little, both of them cause significant trouble. Our goal is to modulate it. Sometimes we have to do both at the same time in the same individual, and that's why the arrival of these new targeted receptor modulators is in fact quite exciting. And finally, non-pharmacological treatments are never to be forgotten. In my personal life, I don't. And I very much encourage you in your own personal life to make sure that these non-pharmacological interventions of sleep hygiene and exercise and mindfulness practice, they are employed. It's also important for us to teach it to our patients because it's important. With that, I would like to thank all of you for your very kind attention, and I wish you and your patients the very best. Goodbye for now.